Let's see. This is probably the last lecture time. I'm not going to be here. I have a request from a higher authority not to be there, my wife, on Friday, and I have to observe that. And so Friday, I will be available. You can email with questions anytime. I'm going to be around, but I will have finished all the lecture material. By the time we complete here today, I'm sure. And then secondarily, so on Monday, if you did not know, in the morning is Science Day here. So I forgot to tell the other class, but I'll send another email, of course, that I know what's going on with your other classes, but our science students, typically juniors and seniors, have presentations. There's a lot of stuff going on in the atrium where all of our offices are. We convert that, presentations, posters, a variety of activities, and most importantly for students, food, and I'm cooking. This is my want. So around, and we do like a buffet style lunch, which you're more than welcome to come. I'm doing jambalaya and I'm doing a rum cake. No age restrictions apply for the rum cake. Okay, you don't have to be there. You can go get another sandwich from wherever, or a salad. It's live a little. Yeah, and yeah. I always put the dietary information on. It's what I do. So on that note, let us begin. So there's not a lot of topics, really. Comparatively, we'll be looking at animal bite wounds and human bite wounds. We'll be looking at tetanus. We'll be looking at some odds and ends, and we're going to be looking at burns and Pseudomonas infections, which are not necessarily all burns. First, let's begin. And so if I forget to do it, let me say, I mean, the core folks are here. Bless you. Thank you. I'm waiting for the wagon train with my injured player, but that's okay. Maybe they're busy. It's for many of you for an entire year. It's truly been it's a privilege to allow me to present material to you that hopefully helps you career-wise going forward. It's an honor. I mean, that's the way I view those things. I mean, you kind of let me a little bit into your lives to do this stuff, and I mean it's sincere. I'm not just blowing smoke. It's not what I do. Okay, every year, because hey, I'm running out of years to do this. I'm trying. I'm thinking. I told my colleague 5 more, guaranteed to be here for 1 more, and so I'm still going to be here. So whether it's from any of you, patho or farm or whatever, if you got questions, just shoot them my way. I'm happy to do that. Don't be a stranger. Remember, so there's that. So I'll get through that portion first. And then, of course, we'll see you for finals. But so that's really the answer, because it doesn't. Monday, we're too busy with that to really do anything else. So I mean, review, have the review stuff, questions, whatever. So get on with the show. Pseudomonas aeruginosa. It's a real big problem because it's very, very hard to treat. It's an aerobic gram negative, and that's an odd combination for something that's a common contaminant. And any of the ways we treat this with antibiotics, typically with gentamicin, which is an aminoglycoside, have side effects. They're pretty dramatic. And so it's a real tough player, particularly if someone would be allergic to that. Burns are thermal injuries. They destroy, it's just like my wife's poison ivy, same idea. It's like 2nd-degree burns that are massive and irritated and have an immunological component. But where we do see this mostly is in burns, is really where you would have the most experience with it, I think. And burnt tissue doesn't have to necessarily be a 3rd degree or full thickness burn. Burn tissue, particularly 2nd degree or partial thickness where they blister, all of that dead tissue from thermal necrosis is comfort food for Pseudomonas. It's just the way it is. It's surely the one you see the most. We had a case in Philadelphia when I was a resident. There was a fire at a hospital about 8 to 10 blocks away. We were St. Luke's. This was at St. Joe's Hospital. We had similar patient populations. We got an alert came in. All of a sudden, they got with all the doctors and nurses, say, "Hey, there's a fire. They have to evacuate the hospital." And we got a bunch of patients and a lot with burns. They're on the sun porches, 3 to a room. We got people all over the place. And I'm touring with, and I'd heard this doctor speak, a plastic surgeon, and they're trying to deal with the burns. And this poor man, I'll show you the picture. This is all over not this picture, but this kind of stuff was all over this guy's back. And and just pain, and with just so many people, he just got a pair of gloves on and literally pulled off all this green, smelly, yuck skin. And basically, it's a kind of what we call debridement or debridement, removing the debris, because it's in that debris. And that's part of the way we treat burns. There are two things where burns are problematic, and they're sort of, to me, 1 and 1A. Fluid and electrolyte loss, which is the immediate problem, and burns and getting infections, because they do them both all the time. So it's really a unique infection. There's a lot of areas where you can't take plants and flowers in because it's in the soil and it's on the bottom of your shoes. It's everywhere. It's on the vast majority of our skin in some places. Typically during the day, it just is. And because of its resilient nature, if that's the right word, its inability to be treated satisfactorily by most antibiotic, it's a big problem. These are just some of the areas. Drug users, piercings, contamination of various things we come in contact with. It's kind of changed the old swimmer's ear and things that we come into contact with now. It forms biofilms, particularly problematic in the lungs with cystic fibrosis. It is a bad guy. And understand what a burn is, a thermal injury. So it can be hot, it can be cold, it can be electrical, chemical, radiation. Even though there's certain nuances with them that you have to address, basically it's the same kind of destruction. Like I was telling you about my wife's poison ivy, which thankfully is finally starting. I mean, that was just yesterday was her first kind of full day out. We're out and about for 4 or 5 hours. I mean, it's nasty. And it has this, and from what I've understood, when you work with it in the lab, you didn't see the characteristic green culture. If you had streaked it out on Mueller-Hinton, the plate that you used for doing the culture and sensitivity, the Kirby-Bauer test, it would turn bright green like this. It always does. Most of the strains have this particular fluorescing agent, this pigmented agent, and and it's also part of its virulence. So ones that pigment, and maybe the ones they ordered we were trying to make them non-pigmented because they would be less problematic in the laboratory if there was a spill or an accident. Perhaps that's why it was. And it's gram-negative, so you can get gram-negative sepsis with these kinds of things. And it's just nasty. It's just nasty. Delays healing. It's got toxins. These pigments are certainly virulence factors that are associated with it. So it's understood. Understanding something doesn't make it any easier to treat. Widespread all over the place. If there's moisture in soil, it's there. It has a remarkable ability to survive if you think of it, even pump soap, where it gets kind of crusty, betadine, that you might have that gets kind of crusty in the lid, the stains that you had in the lab, all that crystalline stuff that was going on, that's where Pseudomonas can hide. We're not even talking about all these other areas. This was the big problem. People were always bringing in, we'll bring in a plant. Grandma's going to be in there for a week. She had a hip surgery. Now we get people out more quickly, but it introduced it into the area. So all of that is part of it. A lot of resistance, the biofilms, appropriate treatment. And again, the part of what makes you about burns, which I stated before, it's the old story. If there's one product that works, if there's one product we all use, it means it's the best choice. So topically, not that it only does is prevent infection. And I waited. Okay, again, the best product. I don't think it's a test question. Silvadene cream. We all use that. Burns are very complex, depending on where if you're here working locally and doing rotations. There are 2 burn centers here in Pittsburgh. I am convinced that the reason UPMC bought Mercy Hospital, which was independent, okay, because they're a certified burn unit, that became UPMC's burn unit. Allegheny Health has been associated with West Penn Hospital. That's the other burn unit. Those are the 2 burn units in the city. So burn panning, again, I don't want to go into the criteria. I did that in anatomy for when I do my anatomy lab. Maybe I did some in anatomy for you about the criteria for referrals to burns. It's very difficult. It's also, for some of you, that's who you see, because a lot of times burn make it difficult to breathe and swallow. They affect the pharyngeal area. So burn patients, that's where you get your first look at TPN. We used to say feed intravenously. It's called total parenteral, which means not through the enteric system. Total parenteral nutrition. And it's very complex to do those things. It's the type of thing you do when you're very sick. It's very complicated getting the right measures. That's why they're certified burn specialists. We happen to know the ones. When my first wife had grown up in the neighborhood with one of the doctors who was on in the East End of Pittsburgh, who was the team at West Penn. Interesting. Sort of a unique thing, and we may end up being, it's not easy, particularly with children, because you got to debride and pull off this stuff, cover them, and it hurts, and it's just they look bad. Finally, tetanus. This is not a pleasant picture. Infants get this, the most common cause by far. I mean, there are not a whole lot of parents in the room, I'm guessing. Okay, when a baby's, remember, we adopted our children, but 2 of them came. My son, my eldest, by day 2, actually saw him, I think, day 1, and my daughter like day 1.5, and they have a stump from the delivery, from the umbilical cord. It's designed to necrose, to turn black with something we call dry gangrene and fall off. So you gently dab it with dilute peroxide and do very little to irritate the stump, and you allow it to fall off, which they do if it's done properly. The trouble with being mishandled, and we'll talk about a lot of these problems in 3rd world countries, war-torn, disease, low socioeconomic, all of the above. It's not so easy to do all those things. And what happens if they get infected? So when a dry gangrene, which we're going to talk about in a bit, which is generally due to lack of circulation or basically removing it from the blood supply, such as when baby's delivered and you clip the cord, if you manipulate it too much and irritate it, it gets what we call wet gangrene, an infection. That's a real agent area where strict anaerobes like tetanus, Clostridium tetani, we talked about it early in the course, will flourish. That's typically what you see this. Everything goes into spasms to break bones. What happens, you might remember when we talked about it for AP1, to go make a muscle move, it's a 2-nerve circuit. You have one in the central nervous system, brain, spinal cord, and a second nerve going out to the muscle. It's here at that synapse. There's the upper and the lower motor neuron. Just to review, it's here, and nerves from the central nervous system don't all produce one neuron. It's like that they don't make acetylcholine. They typically have 2 agents. One will be excitatory and one will be inhibitory. What tetanus does is it gets into those motor nerves. It's a neurotoxin. It travels along nerves very rapidly, and it blocks the release of inhibitory, and I think it's glycine that it blocks the release of. And what happens then, your nerves are constantly stimulating your muscles. It's muscle tone. Constantly. Keeping them, basically keep moving them, keep them active, use it or lose it. The trouble is every stimuli they get is excitatory. Contract. And eventually all they have is spasms, no signal to relax. Those spasms, like I said, will break bones. Eventually it's respiratory. The other thing that it does, it will cause vomiting because of spasms. in and around the digestive tract area, even though those are smooth muscles, the surrounding tissues induce that. And the worst kind of pneumonia evolves from that, which is called aspiration pneumonia. You aspirate, it's like vomit, and this is the real problem. Like somebody who's been recovering after surgery, they're lying flat on their back almost invariably. If they would start to vomit, it's not like you and I, oh, I'm getting sick, turn your head, because we have enough conscious. They're in a still barely out of the comatose state, and they'll aspirate that with all the yuck from your stomach, the acidity, the enzymes that are there, and I mean it's very, very difficult. And that's produced a lot of fatalities. The single most important preoperative order, and the only one you can't fake, makes that much less of a likelihood or a possibility. And that is these three letters you will see. NPO, non-pars oral, in by mouth after midnight. You have a patient, from a teaching perspective, when you're telling them, oh, look, doctor wants to operate on you, we're going to see you in 2 weeks, you're going to show up in the morning, nothing passes your lips by midnight. Maybe you can have a sip of, you have to take a pill in the morning, it's okay to take that pill. A sip of what? Period. Because anesthesia makes a lot of people nauseous, so they take a lot of precautions, and then they vomit. And that's the only one. You can always get blood tests if they forgot to do X-rays, medical consultation, a cardiogram. That's nothing. You can't fake it. What do we do if somebody comes in emergency room, we have emergency surgery? Then you have to do invasive procedures. You have to catheterize. You have to use a nasogastric tube. Then you have to deal with why they need emergency surgery. That's like a kill them and put up with the potential complications. Very important point. It has nothing to do with the test. So here's the situation here that causes it. I saw one case, it had nothing to do with what you and I would consider a typical tetanus-prone wound. It wasn't a cut. It wasn't a laceration. It was, and I didn't see the case to its end, unfortunately, through the demise of this individual, and you might remember me mentioning it in passing, perhaps. It was frostbite, a thermal injury. Eventually, it's kind of like with the stump. Thermal injury, and this man who was a street individual, homeless, you ever see him with the fingertips out of the gloves that are all torn all the time? He got frostbite. You don't necessarily get frostbite in the middle of winter. You typically get frostbite when the temperature is a little above freezing and moisture. That combination of wet and cold is very bad. Soldiers knew about that in wartime. Foot care was extraordinarily important because they got trench foot and things like that. But that one of the things with wet socks and stuff was like, hey, frostbite. So moving on, that's a thermal injury. His fingertips got necrotic. They died. They had to be amputated. I can tell you, I was a senior resident. I was on another rotation. This came in probably February or March of when I was leaving residency and completing my residency, going to practice. I saw him, what's going on? Oh, he had frostbite, they amputated. I didn't think to ask about tetanus. Nobody. But it's a wound, but you don't think of it as being a wound. And obviously, tetanus had flourished by the time the gangrene got worse, got sufficiently bad, choose whatever term would be appropriate, to amputate. The next thing you know, I heard about this. I met up with the folks in the residency. I'd come back to give a talk, which we typically would do, at 6 months, and they go, and they saw the whole thing. Carpal pedal spasms, the muscles going into spasms, couldn't breathe, finally succumbed to, some type of respiratory illness, pneumonia. It was all because of that. They didn't think about the tetanus prone. And surely in a homeless individual, it's unlikely that they would have adequate tetanus prophylaxis. So this is why it's such an important question that we ask. It's so important to take a history and to respond appropriately. This is the name. It's called tetanospasmin is the fancy name for this toxin. It's one of those AB toxins. but neurotoxins work faster than most because it travels along nerves. There was just an article in the paper or on websites. Somebody was in some foreign location and a cobra. They died from a cobra bite. It crawled on their leg and bit them. That is also a neurotoxin. Rattlesnakes are hemotoxins. So that the rapidity of the toxin is significant as there. So this is basically everywhere. We classify as, and you'll begin to become aware, is it a tetanus or non-tetanus prone wound? Even a non-tetanus prone wound that gets infected, a surgical site that gets infected, in the back of your mind, you're going, this is looking a little sketchy. You got to be, it's, why do I think of it? Because somebody at the hospital I had my residency certificate from missed one. And you learn from mistakes, even if they're not, quote, directly your own. Particularly when they may very well most likely cost this poor gentleman his life. So it's kind of everywhere. There's certain, we think of bad, dirty stuff you have to flush out. Okay. It's in the developed world, it's relatively, there's a limitation in the developing or poor, war-torn areas, whatever definition you want to give it. And that's that cord one, and I'm pretty sure that's the culprit. That's there. So what we used to do when someone came in and they couldn't talk, or they were, you have somebody who's overdosed and they're all messed up, massive injuries. You don't know. So you have to presume that they're not tetanus current. And because if it's a tetanus prone wound, understand this is immunology. You all had this in AP2. It takes that tetanus shot is going to take probably between a minimum of 3 weeks to build up enough antibodies. This toxin is not going to wait that long. It's not the wound that kills them. Okay, you could chop off the finger or the toe. It's that toxin. And the only way you can stop a toxin is with an antitoxin. So you don't have the luxury of waiting the 3 to 6 weeks for your immune system to ramp up for that challenge and make the toxin for you. That's how antitoxoids work. So years ago, we used to use horse serum. It was made in horses, and it would take the serum, but because that's not from us, we even use a little drop just to see along the eye, teeny tiny amount, to see if there was an allergic reaction. And then this was one of the very comparatively early genetically modified things that were made. This antitoxin is an antibody. It's all made out of proteins. Now it's made genetically. So this was extracted from a human who had a tetanus shot and was isolated, and we knew the formula and made it in the laboratory. So there's less problems vis-a-vis allergic reactions. So it'll go by hypertet or TIG or whatever they're going to call it. So, and we know the antibodies, they basically neutralize. That's what antibodies do. They neutralize toxins. And there's other things that are used along with it. And again, the antibiotics, you want to kill the cells that are there. You still want to use antibiotics. So don't forget any of that. The tetanus vaccine and tetanus toxoid are both used. This is a typical treatment chart. I'll give you my spin on it and the whole idea. And I never like to use the term minor. I use tetanus prone and non-tetanus prone wounds. Again, the vaccine is diphtheria and acellular pertussis. And again, that's the one that doesn't work necessarily quite as efficiently, but tetanus. So we get them all. And again, the reason we give them a tetanus shot is we don't know when they're in a clean wound. It's always, let's keep them tetanus current, because you never know how soon they're going to get health care. If they're out in the woods hiking around and fall off a cliff or something like that, some room where it takes 2 days to rescue them. Pregnant mothers to prevent neonatal. And again, if you have experienced tetanus and survived it, it still doesn't provide immunity that's there. This is why there's a limitation on it. So in these kinds of cases, Clean minor wounds, we don't have to worry. Look, if it's not a tetanus-prone wound, do we have to use the globulin? No. If we don't know or have a reliable history, we give them a tetanus shot, the DTaP, toxoid. If we know it's more than 10 years, most places are going to push, if they don't think it's a reliable history, or you particularly see a lot of people, I'm tired of getting a stupid shot. And I commented on this before to you ages ago. A lot of us, when you get to my age, they keep giving us those blanking shots. Okay. And you go, oh, just tell me how 2 years ago. That's where your interaction is critical. When was your last tetanus shot? Oh, 2 years ago. Patient states had tetanus prophylaxis 2 years ago for their chart. You are now legally fine. You have not done your job completely. Because understand the premise of the great show House. Patients lie. They lie all the time. We're tired of getting those blanking shots. Oh, really? You had a tetanus shot too? What happened? Did you get a cut? Did we take care of you? Conversation. Oh, yeah, you guys. Now you go back and look at the medical records. We can't find a record. You sure it was this hospital? No. Well, we better give you another to make sure. If we don't have reliable records. They did that to me. The dog, he was a puppy. So this is 4 or 5 years ago. I knew I'd had a tetanus shot in 2019. I knew. The guy there is going, well, he cut your foot. By the time he figured I was a doctor when I was talking to him, he goes, we should give you a tetanus shot. I have one, I'm sure, 2 years ago. Blah, blah, listen, stop the sales pitch. I understand what you're doing. I appreciate it. I will personally contact my doctor's office tomorrow morning and find out exactly when they had that shot. And if for some reason I am mistaken, I will come back here and get that tetanus shot. And it was in a tone that did not leave room for further conversation, if you get my drift. And it was 2019. Keep a record. So all of those, and this was within 2 years. So it depends on the facility. They may, and I understand, I accept the fact that they're doing this for the right motivation, not just for monetary gains. All other wounds are tetanus-prone wounds. Is it irregular? Is there dirt in it? Is there a high incidence of risk? Is it a drug user issue? Who knows what's involved? If we're not sure, is bone exposed? All of those require. So if it's unknown, for sure, you have to use the immunoglobulin. If it's unknown, for sure, you have to give the toxoid. I don't get this. I would, to be very honest with you, in a tetanus-prone wound, if I knew it was 5 years or less, my guess is, I could buy this one. Once I get to that 5-10, I'm giving them the toxoid. And if I'm the prescribing physician, I'd rather give them the immunoglobulin. And certainly if it's more than 10, I'm giving them both. What the fudge? Are you not giving them what? It's not it. It makes no sense. So again, I'm working on the assumption that this is a PowerPoint graphic error. But again, depending on the facility, there will be a protocol to follow. But in the future, many of you may be the ones making that decision. For instance, a nurse practitioner would be making that decision in the facility. So you'll have a protocol to follow, but sometimes you have to adjust as to circumstances. That's the best I can tell you. So typically, if we're not sure if it's a tetanus-prone wound, if there's no other allergies that could, you're going to have to use tetanus without a reliable history. The tetanus shot, the immunization, the tetanus immune globulin. And look, if it's that bad of a wound, you better have them on some kind of antibiotic. This is the least common gangrene. We saw plenty of this in individuals, unfortunately, with wounds and things like that. It's less common today. We saw it in people who really didn't seek treatment quickly enough, and it just blossomed. They're usually people who had underlying health problems associated with it. It's kind of like, in many ways, like the same deal as that necrotizing fasciitis, except it's more destructive. It produces a lot of gas. That's why we call it gas gangrene. It's a gas-producing anaerobe. Typically, there's many, but the most common by far and away, Clostridium perfringens. And it's almost like the skin's ready to explode. It's very painful. This is not, you're very aware of this. You can smell it. It has a very distinctive odor. Crap oozes out of it. Fluid leaks, frothy looking, short incubation. The skin discolors. That's there. And then at the end, now this toxin's everywhere. And most of the time, you're not going to save that person. So, I mean, it's really, you're thinking amputation from word go. Like someone came in with a foot like that, they're having a below the knee amputation, minimum. You just don't, I mean, there's, in the science of amputations, there's a couple of good ones. You try to leave the knee intact if you have the option, because it absorbs a lot of rotation. Okay? Clostridium perfringens is most common, another one of those gram-positive, same family as C. diff, same as botulism, same as tetanus. It's different. The gangrene that you're going to see the most of is called dry gangrene. That's in the diabetic toe. That's in diabetics in general. What happens is a circulatory blockage. It does not involve a microorganism. If it's not treated properly, just like that stump, what we would do is you would gently use something like lamb's wool, separate toes if it was on a couple of toes so they didn't come together, because that friction would be enough to start an infection. You gently dab them with dilute peroxide and have the staff do that X number of times a day. Very, very gentle. We have what's called a cradle. Cradle is like a metal device that lifts up the covers and the sheets so they're not pressing on the toes. Because that pressure alone will cause, and if that is not done, if it's not treated properly at home like that, what happens is they get wet gangrene. So, and that's kind of like the stump. Starts as dry. If it's not treated, it gets a secondary infection, and then that fulminates and really predisposes to things like tetanus and other kind, even gas gangrene could come from that. I mean, it's really so dry. The whole idea is called demarcation. You leave it alone, and you basically, just like you would in a stump, an umbilical cord stump, like in my case, you let it fall off, and you have what's left, and skin's underneath, and everything's fine. Same thing here. As in nursing, you'll go in the morning, make some rounds, and you will. Don't be surprised, depending if you're dealing with a lot of diabetic population. Someone's in because of gangrene, and we're watching to see if we have to amputate. And what happens? Oh, Mr. or Mrs. So-and-so, how are you doing? Let's take a look at that foot. And all of a sudden, you're going to see a piece of a toe in it. But the stump should look good. So don't be shocked. You see a lot of stuff that's unexpected. And I mean, there's a protocol for the toe. What would you do with the toe? Well, if you fell off, you would throw it away, would it? No. Under the pillow. Under the pillow. It's like the tubes in the ear. There's a toe fairy. There's a tube fairy. There's certainly a tooth fairy. You guys are awful. I mean, if you went to the class play and they were doing Peter Pan, they said, do you believe in fairies? And you clap their hands. Remember that? You'd be, oh, that's terrible. Tinkerbell would never. I told the other guys, a great movie with Johnny Depp and Kate Winslet called Finding Neverland, where it's really this true story, obviously fictionalized for the movies, where Johnny Depp plays J.M. Barrie, who's Scottish, who wrote this brilliant play, and still done. The music's brilliant when it became a musical. And it's just about, it all involves her kids. Interesting. And he was married to somebody else, but that's an aside. But it's a really nice watch. So if you get a chance, you could find it on YouTube with commercials almost anywhere. It's been around. It's like at least 20 years old. So that's the story with this. Two main factors: gas gangrene, dirt and dead tissue. Delays play a role. Lots of enzymes play a role in the pathogenesis. The toxin is very nasty. Cytokine releases, so it triggers a dramatic response. That's real. I mean, this is part of the reason we talk about. Remember, I told you way back when they were talking about sulfa drugs, how that was in wound packs. I mean, a lot of that played a significant role. That was sulfanilamide in those packs that was able to try to, at least put something on there to limit the likelihood of gangrene that was going on. Occasionally, surgical wounds. This is one of the reasons these self-induced abortions, or people doing untrained abortions, because this is found vaginally in some individuals. They would have a gangrenous uterus. And imagine how just the tragic disfigurement, the life-threatening nature, and a lot of that, you guys weren't around. That's what kind of why Roe v. Wade was enacted in the Supreme Court, because there were so many abortions were being performed by people who were untrained, illegally, or self-induced, and women were dying. So I mean, whatever your feelings about terminating pregnancies are, that was the logic back then. I mean, and change. It's just it's an interesting discussion in another classroom, more or less than anything else. It's more legal and ethical and what's going on around in the country, etc. So I mean, there's lots of different things. Diabetes can be underlying. It's so important to, when you gas gangrene, we debrided those very uh, uh, efficiently, very actively, so to speak, thoroughly. And hyperbaric oxygen is useful. You have to, not every place has hyperbaric. Usually there are larger hospitals. You can do it on a limited, particularly burns units would have that. And then now we get to the last major topic, which is bite wounds. The two big players for bite wounds are Staph aureus, and it's not MRSA. This is a interesting staph. It's a beta lactamase producer, and we find it in all animals, cats and dogs, which are the most common ones that we see. Beta lactamase and something called, losing my thing here. You'll see the name. It's Pasteurella. You'll see it better. Multicida. It's on this, but my marker got left in the other room. And that's why the drug of choice for this is augmentin, because it's a beta lactamase producing staphylococcus. And Pasteurella multicida is a fairly easy to kill gram negative. Common. My granddaughter, which had this baby for my great grandson, when she was 3, she got nailed by the baby daddy's stepfather's dog on Christmas Day in New Kensington. And they very fortunate. One of the rare cases where they elected to suture this. It was a 24-hour wait at Children's Hospital. So you had treated, thankfully, whoever was the resident or the attending at that place had a lot of experience, knew what they were doing. And thankfully, the dog nailed her with several stitches along a crease here and a crease here. So it was in a natural crease and did not scar. You wouldn't look at her today, you would not even know that it was there. Treat her with antibiotics. Normally, you do not suture animal bites. They all get infected. It's rare. They gave her the augmentin. They did the suturing. We watched. We follow up almost on a daily basis, because when we get infected, you have to open it up. One of the things you will do with dog bites or cat bites, typically dog bites, a dog is more of a grab and think of my dog trying to get the ball away from the throw toy. Cats more nail you. Okay, it's more of a puncture move. Cats, if anything, I think are more prone to create deeper problems. And dogs, we're about tearing. So a lot of times, if we do sew them, we do what's called a retention suture. This is a suture that's going to be removed. All it is to try to hold the tissues together so that they're going to have some kind of plastic surgery down the road. And you're trying to deal with that. The same is true for human bites, which you never sew other than just something, because cosmetically down the road, 6 months a year, we're going to probably have to have some kind of plastic surgery. This is a lot of problems. I find the crushing and lacerating much more with dogs and the puncture more with cats. For my first marriage, I told the other group, my wife had already gone back to Pittsburgh. I was in Philly. We had 2 little kitties. The one kitty was skittish, was under the cabinets in the kitchen. We're going to try to get him because people are going to watch the kitties. And she nailed me right here. Like the day I was getting her there and leaving for Pittsburgh right after it. 5 days into our honeymoon, guess what? Infected. I'm on Space Mountain in Disney World. And it's like, oh my God, my hand blew up. What's wrong? I said, we're going to have to go get this looked at. And remember, this 50 years ago. It wasn't as busy. There wasn't a whole lot to the Magic Kingdom then. And they had this little clinic that was on the grounds. And they basically gave me antibiotics and a tetanus shot and said, it should go. And it did. And it was because I dismissed it, washed it, put topical antibiotic. Because I thought it was superficial. It was really deeper. It was more of a puncture. But this is one of the things. If there's a lot of anaerobes, these get smelly. Human bites, much more so. So if you go back and look at this, animal bites, a lot. Human bites are more serious. The human mouth is much more of a cesspool than when animals have more inherent antibiotic type or antibacterial substances, in their saliva, the IgA, all of those types of things are inherently because they lick their wounds, much more so. The human mouth is awful. It's complicated by hygiene. It's complicated by a variety of other factors, gum disease. There's a lot of anaerobes. I mean, if this isn't a fight and you nailed somebody with this, it's going to blow up like a balloon. And it's awful. And the 2 things that we see consistently, can only hope, that are associated with this and everything. Oh, my goodness, right. Okay. Basically, stimulants like amphetamines, speed, Adderall, crystal meth, whatever you want. There's so many names for them, whatever the appropriate name. Amphetamines, and it's a terrible combination, and it can happen individually, and alcohol. Alcohol is a disinhibitor, meaning you might find people who have a couple of drinks who are normally very quiet, and all of a sudden they do things that are very unexpected because it inhibits. You have in your brain things that keep you sort of doing things that are societal norms. And some people, their behavior changes dramatically. If you see chronic amphetamine users, they are extraordinarily short-tempered, extraordinarily angry, extraordinarily violent. It was really the drug of choice for biking gangs forever. And boy, that combination, it's just, you don't go into biker bar and start a fight. Just be careful. But that's typically somebody punches somebody in the mouth and they get a bite wound or they take a chunk out of them. It's nasty. So that's one. You really have to watch that combination. It's always infected. You don't want to sew those things up. Bacteroides is very common in our mouths. We have a lot of anaerobes in our mouths that are there. And I mean, and all of this is true. Aerobic and anaerobic species, crushed typically. I mean, if you're in a fight with somebody, they bite you. All these enzymes that are typically there, this combination, fights due to drunkenness or during forcible restraint. Fourth, mouth hygiene. I told the other class, there's a guy up the street from us who lived next door to the mayor when I lived in Oil City for 12 years. I pull up in the car, they know I'm a doctor. I say, oh, yeah, our dad fell down. Could you help him? I get over there. I know I fell down. I mean, you could smell it a mile away. He was drunk. And we kind of knew this was not the first. And I think they wanted him to get him off the curb and halfway in the street because he'd had a couple of public drunkenness problems. I start to lift him up. He's taking a swing at me. I'm like, check, please. You're gonna have to take care of Dad yourself. I mean, I wasn't going to make a federal case out of it or call the cops. It's like, I'm sorry, I can't help it. They said, oh, it's okay. Thanks for trying. Watch out. So immediately opening it rather than sewing it, lots of antibacterials. Yeah, avoid situations would be nice, etc., etc. And again, that's all part of it. Here's the one I'm sorry I couldn't write it for you. That Pasteurella multicida is the name of it. And again, that and the Staph aureus are typically the combination. And it doesn't take long. It's a gram negative, thankfully, that's easy to treat, but it has a lot of long-term complications. It is very susceptible to penicillin. So the beauty of ampicillin with the beta lactamase inhibitor, what we call augmentin, really works well because it can take care of. Thankfully, this is a more easily treated kind of Staph aureus, and it will also address satisfactorily the gram negative, the Pasteurella multicida. And so and that's well known. There's other things, cat scratch, and particularly because think of where even in the house with regard to like litter pans and things like that, there's some problems that can be. You don't have to know this. It's just informational. Effectively, we're done with the test material. It has a name called Bartonella Hensley. If you're interested, the reason I tell you about this, these are the kinds of things you never know when they're going to throw something like this at you. Okay, and it's particularly to cats. It's not spread person to person. I mean, again, you got to be careful. Cats, particularly feral cats, they're unpleasant and nasty. We encountered this in medical school because we used rat experiments a lot. Unfortunately, did a lot of vivisection, which I mean, it was a different world 50 plus years ago. But I mean, we sacrificed the rats and we inject them with things, see if they had allergic reaction. The rats weren't very happy about this. And so that was and really the problem was less about rat bite fever and more about tetanus. Because we asked about that. And they go, well, we learned about this. They go, look, our big problem is really with tetanus. We keep an eye on it. Well, they gave you antibiotics, but basically the tetanus shot was a critical piece. Particularly when you're dealing with live animals, but typically lab animals they get from pretty reliable sources. And one more I think is here. Yeah, this is the last thing. And again, informationally, rose gardeners. This is a fungus. So I mean, for people who go, you got to be careful. There's so many thorns. I mean, it's easy if you're going in there. You get jabbed enough, it will embed or implant. It's a subcutaneous implantation of a particular fungi called sporotrichosis. The name comes from that Sporothrix schenkii. I don't have to know about it, but this is something. But I mean, diagnostically, if you see somebody, you see this line of like little, little puncture wounds. I mean, in the back of your mind, that's something that could be on something with thorns could theoretically do this kind of thing. And the treatment is antifungals, probably orally, as much as anything else. And that's it. We're done. Stay complete.